the questions by asking Dr. Frenette. I heard you say that our HCC patients are not benefiting by sending them to a low meld place like
A short wait time place.
a short wait time place like, well, I'm thinking of Ochsner Clinic in New Orleans. So,
Right.
and we have patients that, and I'm sure the big programs in LA do too, where the patients say, I can afford to go wherever I want, and blah, blah, blah. Should I go to New Orleans or should I go somewhere else? So.
Right. So I cut out one of the abstracts just for time, but there was an abstract that looked at what the effect of the 6-month mandatory waiting period was. When they looked at that by long, medium, and short wait time, there is a slight benefit of a higher chance of getting transplanted. It's about between 5 and 10% chance that's better by going to a short wait time period. However, the post-transplant survival is worse because if they have aggressive tumor that doesn't declare itself before transplant, then they're going to have it come back after transplant, and we all know that that's a bit of a mess. So that's really the key. The patients within Milan criteria, it doesn't really honestly seem to make much of a difference one way or another, both on wait time, dropout risk as well as post-transplant survival. But the patients who are being downstaged, it actually hurts them in the long run as far as being able to do well after transplant, just because if they get transplanted too fast and they've got a bad actor of a tumor, they're not going to do well. Now, I will say this with the caveat that as of Thursday, this past week, UNOS voted in an entirely new liver distribution system where we basically almost get rid of regions. And we have no idea what's going to happen with that.
So let me ask the same question to the USC folks. You guys got living-related liver transplant. Jeff, you want to start off? If you got somebody that meets criteria, it's got a living-related donor, you're going to make them wait 6 months?
I think it sort of depends. I mean, we see a lot of patients that were diagnosed, some time ago with HCC. We look back, they had scans, 6 months or sometimes even a year ago. So sometimes we see the natural history just, when they come in with all of their old scans. I think if we think they're borderline candidates because of, they're sort of at the stretch of Milan, I think most of us would prefer to try to treat them and see if they're stable for at least 3 to 6 months. But the other bad group of patients is the decompensated patient who has a tumor that's 4.9 centimeters.
And an AFP of 250.
And so in those cases, I think, sometimes we might just decide to transplant them sooner than later because there probably is no later for them, recognizing that there might be some increased risk of recurrence.
How about you guys at Cedars?
I mean, we use the wait list. We like to see stability of the cancer before we put them on a transplant. And the other items we look at is the AFP trend. We want to make sure the AFP drops to less than 500 at least before we consider them for a transplant. There is strong data to show if the AFP is over 500, the risk of recurrence after transplant is pretty high.
And they're actually changing the HCC meld exception rules that you have to get the AFP below 500 before they'll give you your exception. So UNOS is putting in that criteria. In the next few months, that's going to go into effect, where you will lose your exception and not get it if you're over 500 at the time of the exception. Now, if any time over 500 they treat, it goes down. But the data that Neil Matus had presented that I showed you suggests that we should even be worried about an AFP of 100, which is much lower than data I had seen before.
Graham.
Great talks this morning. I guess this question will be directed towards Kris. As we all know, gastric bypass is one of the best treatments for NASH, so I was a little disappointed in the results of that study, showing that in cirrhosis, it was not helpful. My question is, did they break it down into Roux-en-Y versus gastric sleeve, which is a more benign procedure?
I can't answer that because I don't know. What I would guess, though, looking at the period of time, 2005, 2016, is probably much more likely to be a Roux-en-Y as opposed to a sleeve. I would say it's only in the last I would say 2 years, that sleeves have largely replaced the Roux-en-Y procedure. So it's an excellent point, because we know that even in the setting of decompensated liver disease, there are data, anecdotal case series that sleeves can work pretty well. I don't know.
They didn't have it broken down.
Yeah.
'Cause that question was asked actually at the abstract presentation, and they did not have that data. So that's definitely some data that we need, because I agree with you, sleeves are usually much more benign. And generally in the cirrhotic patient, you want to avoid a malabsorptive procedure, because that's when they really have the issues with more malnutrition, and then they develop the frailty, which Kris showed us beautifully that that's a huge issue.
So what's the answer? If somebody has cirrhosis, you know, we've been presented with these cases where the surgeon freaks out, you know, and says they got cirrhosis and sends them over, should I do the sleeve or not? So what's the answer? They're compensated cirrhotics.
I would do it.
Yeah, I think if the patient is otherwise, I have a patient right now where we are right in the middle of this. She has portal hypertension, has had variceal bleeding, has HCC that I've treated for the past 3 years, extremely motivated for transplant, but she just can't lose weight. And so we've done the medical bariatrics, and it's had sort of a modest success. But I think that this is the patient that I would feel quite comfortable in a very selected situation,
Right.
decompressing the portal hypertension with the tips that she's already had, and then maybe consider a sleeve.
Right.
Would you agree, Jeff?
I would,
what?
yeah, go ahead.
Yeah, go ahead, Saro. What do you?
No, I would also agree that I think since the sleeve is new and certainly more studies are needed, that seems to make a big difference. So I would proceed, maybe decompress them before and then.
We've also had a few patients with HCC very well compensated that were very obese prior to transplant, that actually had sleeves prior to transplant, that actually had mouth exceptions already just to try to improve their post-transplant outcomes, who did very well.
And I think that the good thing about the sleeve prior to transplant is that our awesome advanced endoscopists still want to have access to the biliary tree, which you still do with a sleeve. You know, it's really difficult when you have your Roux patient that now has a post-transplant biliary stricture you're trying to deal with.
Yeah, I
Or
think
the patient who has a gastric variceal bleed, and you're trying to
Yeah.
Oh, God, yeah.
at least identify something and
I mean, I think the take-home message for me was that this is not a benign thing, at least the Roux-en-Y, that the natural history of these patients, once they have bariatric surgery, at least whatever surgery they had, shifts more from a Child-Pugh A to a Child-Pugh B natural history. But at the same time, we should not let significant obesity stop us from considering transplant. So there are these case series, Julie Heimbach has written a lot of this, where they've done sleeves intra-transplant, post-transplant, pre-transplant. So I think for that motivated patient, like the one I described, who just can't get there, I think we should consider advocating for that.
Francisco.
Okay, a question for all the panel. Well, in view of the epidemic of alcoholic hepatitis in the young populations, as we saw, which patients are you transplanting? How much period of abstinence are you required in your center? I would like to your opinion. How are you doing, or if you are doing transplant?
Okay, we got a lot of questions, guys. So brief answers. So the question is, are you treating alcoholic hepatitis, and if so, what's your abstinence requirement?
So we are considering alcoholic hepatitis. We usually recommend abstinence if possible, but if they cannot, we take it on a case-by-case. It has to be first offense, never been counseled, and have good supportive group. There are data and study presented. These are the 3 key factors in predicting survival after transplant.
Okay. Carrie?
And I agree with those 3 key factors, but also insight into their disease. Right. If they don't admit that they're an alcoholic and that the alcohol is a problem for them, they're not going to do well. We do want to see at least something of rehab, so we haven't proceeded into the acute alcoholic hepatitis. It's still hospitalized, but we don't require, we don't have a certain time period that we require.
Ryan, what are you doing at USC?
So we are transplanting alcoholic hepatitis patients. We are part of a consortium and have done actually quite a bit of alcoholic hepatitis patients. We do screen a lot of patients. We will say that we do focus on insight as probably the biggest thing. You know, in terms of abstinence, I mean, by definition, a lot of our patients haven't known about their liver disease and come in very decompensated and cannot actually demonstrate abstinence. So that's always a difficult thing. A lot of our patients are also Medi-Cal patients, where Medi-Cal does have a 6-month, very strict 6-month sobriety rule, despite the fact that we might think that they are great candidates. So that always plays a factor. But we are, just like the other centers, we are doing alcoholic hepatitis in a very, very select few of our patients.
Kris?
So we prefer 3 months, but as was already mentioned, if it's the first admission and there's no documented encounter or contact with healthcare documenting that they were told to stop drinking, and they score high on the social work assessment and have insight, we will consider them at less than 3 months.
They do take the bulk of the discussions in our selection committee meetings.
Yeah.
So.
They take up most of the time, right?
More than just selection, too. Lots of time for everything.
One other thing, though, from our program that I would add is that the patients need to not have any uncontrolled either psychiatric disease. I mean, they really have to, you know, especially depression, anxiety, and also polysubstance abuse.
Absolutely.
Question.
The question is for the whole panel. So we're getting more referrals for, you know, FNT for recurrent C. diff. So for, and Dr. Kowdley, you know, showed some abstract on, you know, C. diff infection causing higher mortality for cirrhotic patients. So for Child B and C, do you have any experience with, you know, in terms of mortality for using FNT for recurrent C. diff in this particular population of patients?
Want to repeat the question?
So fecal transplantation for Child-Pugh B and C with recurrent C. diff. I do not have the answer. I do not know. Others on the panel might. I would hazard a guess that they would not necessarily respond as well as the non-decompensated patient because they're essentially immunosuppressed. So I would look at the a group of patients that have impaired humoral and cell-mediated immunity and see if there's any evidence that they can tolerate this well.
We've done it in a couple decompensated patients and also a couple post-transplants where we were really desperate, and they so far did well, knock on wood.
Okay.
We had 2 cases, one before transplant who did well, but the post-transplant, they kept on getting recurrent C. diff afterward.
Yeah. We have a few patients who are post-transplant have done very, very well with it.
And we had a recent patient who actually had to have a colectomy pre-transplant because of toxic megacolon.
Oh, jeez.
Yeah.
So it sounds like
Not through transplant, but
good.
that wasn't.
So it sounds like none of you have seen worsening outcomes or worse outcomes because of it, other than the natural history of the disease.
John?
So we heard some direct evidence today, and at the meeting there was a lot of mention of the use of statins in patients with cirrhosis, portal hypertension. You alluded to the, or showed us the data for HCC. So what's the general consensus, the use of and prescription of statins for our patients with cirrhosis?
Yeah, that's a really good question. There's lots of data on cirrhosis and statins, as you said. I showed you the HCC data. There's also data with better survival in cirrhotics in general on statins, a 50% improved survival. There was also an abstract at the meeting that showed that in the 90 days after a statin was stopped, that their survival is worse. So the people who, you know, finally somebody looked at their liver tests and they were a little abnormal, and their primary said, oh, stop your statin, it's bad for the liver, and they actually do worse in the first 90 days after that. I don't think there is no guidance right now that says start a statin for liver disease, but certainly if they need it, I don't hesitate in terms of, high cholesterol, history of cardiac disease, history of stroke, any of those indications if they have another indication. And my appreciation of the abstract that I showed was now feel like I have a little better guidance about which statins to choose.
Actually, the updated guidance for NASH now says you can use statins of any choice, but they don't recommend you specifically start statins for NASH,
right.
for a liver disease by itself. So you have to have some other excuse, right? Which is usually not hard to look for, because
you're a man.
Yes,
You need a
right.
statin.
Dyslipidemia, all those things. Sam. So repeat the question.
Yeah, the question is the use of, commenting on the use of TACE and RFA for HCC. We use a ton of it. So we TACE or ablate all of our pre-transplant patients. The ones that we feel are higher risk, like they've got a high AFP or something, we actually have been doing a fair amount of combination TACE followed by SBRT. There was a study that looked at bead TACE versus Lipiodol TACE that showed pretty clearly that beads were superior to Lipiodol in terms of response rates. I can't remember if it was survival. I know that there was improved response on imaging. So we absolutely use it in the appropriate patient, and RFA too, absolutely. We use a lot of, we do microwave RFA, which is a little faster than the old radio frequency and has a little bit better ablation ability than the radio frequency. All right, what are you guys doing?
Yeah, we're using microwave ablation, DEB TACE, more and more SBRT, which I think
And a lot of it may be technically limited in terms of what we pick, in terms of location for RFA, as well as size of the tumor, as well as the presence of portal vein thrombosis, and those things that all have to be considered for the choice of actual local regional therapy.
I just have one word of caution. I think we've sort of gotten into the concept that we kind of believe that SBRT, CyberKnife, is kind of a benign procedure, but I've seen several cases of radiation hepatitis. And so I think it is important that for those of you that refer patients, especially if they end up with a radiation oncologist, they're going to end up back in your practice, just watch out for signs of radiation hepatitis.
Absolutely.
And I think Kerry made a good point. That, if a patient requires multiple TACE, that's a patient you should consider sending for an oncology for systemic therapy. Because once you burn out their liver function, they're out of option for them.
Yep.
And there is good data now coming out showing that systemic therapy could affect long-term survival. So we're not talking about a few months. We're talking about a couple of years now.
Two questions in regards to aspirin and coffee. Is it a baby aspirin? Is it a full aspirin? Is it regular coffee or decaf? And if it's decaf, why would it work?
So the coffee.
Repeat the question, please.
So the coffee, with a question about coffee, is it regular or decaf? And if it's decaf, why would it work? So it doesn't matter regular versus decaf. Both of them have shown a benefit, and it's thought to be antioxidants in the coffee itself. That is why it works. And you get a better response to coffee than you do to tea, because I get that question from my patients a lot. Well, what about tea? Can I have my tea? I'm like, well, yeah, but it's not necessarily going to help your liver. This data, I believe, was a baby aspirin in the abstract. Was it 325? It was 325, sorry, I was wrong. So it was 325 daily that they looked at, and again, the longer that you're on it, the better response. Now, I would caution you, make sure if you're giving your cirrhotic patient an aspirin that you think about varices and platelets and bleeding and all these other things that we have to think about. But as we're seeing more and more NASH patients with cirrhosis, a lot of those have an indication for an aspirin as well.
Regarding the coffee, last year there was a different message. You get a benefit from decaf and caffeine, but the benefit is much superior in caffeine. Caffeinated coffee rather than
The data's
decaf.
a little, I mean, there's been like 10 different
data.
studies. So it's murky data on coffee.
What about espresso versus drip?
They talk
I'm
about
serious.
filters, what kind of filters.
You're out of luck, Chris. You're out of luck.
Espresso doesn't give you the benefit, or
Not
we
as
don't know?
much.
All of these
Drip coffee.
Yeah, all of these studies are very, very difficult, obviously, to do because it takes a large scale,
Yeah.
and it's all based on a lot of journals and and patient reports of how much intake they have. So it's a muddy data. I think we're still learning a lot because the mechanism is still
Don't be
not
knocking my
very clear.
coffee.
Dr. Frenette, on withdrawal of aspirin, your numbers stated that after 5 years you went to 2.16, I believe, implying that you're actually worse than if you had never used aspirin at all. Just a question of that part of your data, or that study that you reviewed.
You're talking about after you stopped the aspirin?
Correct. I believe it said 2.16. It was clearly over 2.
Yeah, so it was that, but that 5 years, it was not, it was basically looking at it compared to when they were on aspirin. So it's not the people, it's not worse than never having been on aspirin. It was 2.6 higher than if you had stayed on aspirin previously. Do you see what I'm saying? So you're basically, your risk goes down, but then it goes back up when you stop. Yeah, but you're not gonna make it worse when you go back up.
Okay, I know you guys didn't hear Patrick's talk yesterday, which is good. I want a no BS answer here. I want Kris, starting with Kris. You got somebody listed for transplant, portal vein thrombosis, not excluding transplant, just it's there. You put them on an anticoagulant, and if so, which one?
Which one, you mean? I think if it's relatively acute, we've used...
It's not acute. Come on,
chronic?
none of these are acute. They're found by accident when you're working up the patient. They get an MRI or CT, and a radiologist says,
Warfarin.
"Oh, yeah, you got a partially
Warfarin.
occlusive warfarin." Okay, next.
So
USC.
we use Lovenox, and really in very select patients who we are afraid that there's actually going to be propagation into the SMV, because that obviously makes transplant much more difficult. But we have been using it very rarely, and we generally use enoxaparin as the first-line therapy.
Enoxaparin.
Long-term, you keep them on it? You don't
So we keep...
transition?
It all depends. We've been keeping him on it, and at least I can speak to my patients. I've been keeping him on it long-term.
Carrie, what do you use? Can we get scripts?
Well, I think it's mean to give somebody shots twice a day.
Yeah, so you
Come
give them
on.
Coumadin. Okay.
Well, so
Coumadin.
Walid.
we did have more, I guess, armamentarium to use actually these DOACs now, which we didn't have a lot of evidence before this meeting.
Right.
So I think we are going to transition a little more probably to these oral therapies.
The only problem with the DOACs that we've been having is that the reversal agents are incredibly expensive and a little bit tough to get. So that's the only thing that we worry about.
But you
is
can
if
get
they
the
come
DOAC.
bleeding.
Walid.
Lovenox and DOAC, and we use one that's a reversal agent. And
Okay,
production.
so Lovenox and DOAC. So if you heard Patrick, what Patrick said yesterday was concerning, because he basically said warfarin makes portal vein thrombosis worse. And he showed data to support that, and he showed, he suggested we should be using enoxaparin, and I don't think most transplant programs do that.
But I think
Or
that,
DOACs.
I mean, I didn't hear his talk, so, but
Yeah.
I would say that, the condition that I would use, and I'm sure Carrie feels the same way, is we don't keep patients on it indefinitely unless they have a JAX2 mutation or something
Some
else.
hypercoag state.
It's a 6-month therapeutic trial. There's
Yeah.
no effect, you're off.
You're off,
So
exactly.
I'll clarify why I say indefinitely before transplant, because most of our patients who have a chronic thrombosis with cavernous malformation, it's not to try to achieve patency, it's to try to avoid extension. And so if they have partial thrombosis of the SMV, those are the patients we've been more likely to place on enoxaparin. And if you stop it, I mean, you're back to the same exact spot you were 6 months ago. Do we continue it? Because is this going to preclude you from actually having a safe transplant?
Wouldn't you argue that if there's cavernous transformation or if it's a chronic clot, your best strategy is to try to do a TIPS and open up the clot?
I think that's. I think there's great data from Northwestern to say that if you have transvenous splenic approach with a TIPS placement with angioplasty of these clots, they do very, very well. It's just that our patients will not tolerate TIPS. A lot of our patients have MELD scores that are far above what you would safely recommend tips for. So I think in a low region place with a portal vein thrombosis with cavernous transformation that you are managing long term with MELD scores that are low, I think it's a great option, and we have done that for several of our patients.
Remind everybody what MELD score you would use.
So there's obviously no great consensus. Earlier data has suggested that people with MELD scores greater than 15 or 18 with elective tips, it is not recommended. Now, there are more data, though, especially in the patients with early bleeding from early tips with high-risk bleeding, as well as refractory ascites patients, that people with bilirubins are greater than 4, they actually do pretty well in the newer data also. So I think we are underutilizing tips for sure, but for a lot of our patients with our MELD score in the high 20s, I'm not sure if that's a great viable option.
I agree.
Agreed.
Yeah.
Good point.
Last question, in the back.
One question for Dr. Pockros in regards to fecal transplants. I understand at Scripps you do fecal transplants. My question is, what are the approved indications? Number 2, are there now fecal capsules available?
So fecal transplants, Carrie, I'll turf that to you.
There are fecal capsules available, but they're expensive. So we actually have some frozen poop in our fridge in the GI lab. We have a GI person that's interested in it, and he does them all, and I don't know where he gets the frozen poop, so I'll just leave it at that. So we usually put an NG tube and put them down there. We usually, and the most reasons that we do it is C. diff, recurrent C. diff.
Okay, I'd like to thank you all for staying till the end. Please fill out your form, and we hope to see you all next year, first weekend in December. We'll go back to that, hopefully.